Good morning, everyone. Welcome to Grand Rounds. I'm Jeff Miller, one of the co-directors of Grand Rounds with Kate Elkington and Christine Denny. We're so pleased that you're joining us today for, I think, a really special Grand Rounds. I just have a few announcements before we get started. So next week's Grand Rounds will be the Viola Bernard Grand Rounds Lecture. It will be given by Dr. Esther Calzada, who's Associate Dean for Equity and Inclusion and Professor in Child and Family Behavioral Health at the University of Texas at Austin. The title of her talk will be Looking in All the Wrong Places, Rethinking Our Approach to Supporting Mental Health and Academic Achievement Among Latinx Children in Marginalized Communities. I also would like to highlight the Grand Rounds that will follow 2 weeks from today, which is also a special Grand Rounds. On Wednesday, April 20th, we will be returning to the auditorium for Grand Rounds in the auditorium using a hybrid format. That means that you could choose to attend in person. It'll be so great to see many of you then, or you could choose to attend via the Zoom webinar format like we're doing today. We will be simultaneously doing in-person and Zoom webinar formats. And that Grand Rounds on the 20th will be given by our own Dr. Suzette Evans, who will speak about sex differences in the behavioral responses to drugs of abuse. Next announcement is that we are still trying to finalize our Grand Round speakers and schedule for the coming 2022-2023 academic year, and we really value your input. We'd like you to complete the survey that Simon will post in the chat. You could click the link now, bookmark it, and complete it after Grand Rounds. We're seeking a diversity of speakers from multiple perspectives, topic areas, gender, underrepresented minorities. And ideally, you would nominate a speaker whose work you know well, but who you also know to be a good speaker. So please click the link. Please make suggestions. It will only enhance the quality of Grand Rounds for the coming year. Next announcement is about questions. We really would welcome your participation in today's Grand Rounds by asking a question to the speakers. To do that, you can submit a question through the Q&A feature at the bottom of the Zoom window. Please use that and not the chat function. And we would really welcome questions from a broad array of our department, from clinical, basic science, education perspectives. We also will prioritize trainee questions. If you're a trainee, please put the word trainee at the end of your question. And lastly, I'm going to make a plug for this. We've now mastered Zoom webinar well enough to be able to allow you to ask your own questions, and we strongly encourage you to do that. I promise you, if you ask a question yourself, it will be much more interesting than my reading the question to our today's speakers. So if you put a question in the Q&A, at the end of the question, please note either can ask myself or prefer to have question read. But please consider writing can ask question myself. If you do that, we'll promote you to a panelist. You can have camera on or off when it's your turn to ask the question, and you'll ask the question directly. Okay, I think that those are the announcements. And so now we will turn to one other thing about questions. Because we have 3 speakers today, we're going to save the questions for the Q&A at the end. We will not have separate Q&A sessions after each speaker, but please put a question in the Q&A at any time. We'll collect them and call on you when it's your turn. Okay, so today's Grand Rounds is part of our clinical update series. The goal of this series is to share the state of the art in clinical practice from area experts in our department. And today's session will focus on the use of dissociative and psychedelic medications in psychiatry. There's been a real surge in interest in the use of the dissociative medication ketamine and its relative S-ketamine as treatments for depression. The latter is FDA approved. The former is used very broadly around the country in off-label use. And there's also been a surge in the use of psychedelic-assisted psychotherapies as more in the research domain. So in the case of ketamine, important work has been done in our department, spanning translational work, animal work by Christine Denny, looking into mechanism, clinical trials by Mike Grunbaum and John Mann, looking at effectiveness, including in response to suicidality, and studies of mechanism in humans by Matthew Milak and John Mann. And in recent years, a ketamine clinic has been developed at Columbia to provide clinical treatment using ketamine and S-ketamine. Our first speaker today, Dr. Joshua Berman, is the founding clinical lead for that Columbia ketamine program. So I'm going to introduce him now. Dr. Berman is, in addition to that role, Dr. Berman is medical director for interventional psychiatry in the Columbia Psychiatry faculty practice and clinical lead for the ECT service at Columbia. He received his undergraduate education at Yale and an MD, PhD in neuroscience from Mount Sinai. He then completed residency training at Columbia and NISP, followed by research fellowships here in affective disorders and substance use. He's received funding from NARSAD and from NIDA. He joined the Brain Stimulation Division and obtained extensive background in treatments such as TMS, TDCS, deep brain stimulation, and ECT. He participated as the Columbia site PI in multi-center clinical trials of deep brain stimulation and deep brain TMS. And the title of Dr. Berman's talk today is Ketamine and S-ketamine, Insights from Real-World Practice. Thank you, Josh, so much for joining us today.
Thank you. Thanks very much. Let me share my slides here. Okay. So this is going to be a sort of a 10,000-foot view of clinical use of ketamine and S-ketamine in treatment of depression. And in some ways, we're coming at this actually from a less dissociative perspective. So it's going to be a contrast to the perspective I think that will be given in terms of use of MDMA and psilocybin. We'll look briefly at why we use ketamine for depression. We'll look briefly at evidence for efficacy, briefly at who gets the treatment and what the treatment looks like, and briefly at a sort of a few questions going forward about where the field could go. So ketamine, as we know, is a dissociative anesthetic, and its primary mechanism likely involves blockade of glutamate receptors, though there are some dopamine effects that are probably less prominent, some probably less prominent indirect effects in opioid pathways. As a drug of abuse, it's taken orally or snorted. Psychiatric dosing, it's important to note, is about an order of magnitude less than anesthetic dosing. And in anesthesia, it's given with a bolus and a continuous infusion, whereas we don't tend to give boluses in psychiatric use. So it's a much more kind of mild treatment than what's seen in anesthesiology. The first psychiatric use was after observation of improvements in pediatric surgical patients with comorbid depression in Iran in the early 1970s. And then interest in drugs like ketamine waned partly in response to kind of the perceived excesses of exploration of use of psychedelics in psychiatry in the 60s and 70s. In the early 2000s, as psychiatry came back towards looking at glutamate mechanisms in depression, there was renewed interest in use of ketamine. And there was this astounding observation, first shown in a study by Robert Berman and colleagues at Yale in 2000, that you could get very rapid antidepressant effects with ketamine. And that spawned about a decade of exploration into rapid but transient effects of treatment of depression with ketamine. When we think of how ketamine might work, we think generally of a trophic model of action in which ketamine produces very rapid proliferation of dendritic spines and limbic circuits, but in a manner that's much faster than what conventional antidepressants do, and results in changes in connectivity between the hippocampus and other brain regions, between cortical regions, and perhaps also involving firing patterns in the lateral lobule, all of which improve the circuit issues that are present in depression. In both preclinical and clinical models, you can see these kinds of rapid effects, although in real life, I have to say that we see a wide range of rates of improvement in patients receiving ketamine. There's a lot of controversy in the field as to whether AMPA or NMDA receptors convey antidepressant mechanisms. In both preclinical and clinical models, you can see antidepressant effects with isomers of ketamine and metabolites of ketamine that variably hit either AMPA or NMDA receptors or both. And there's probably a likelihood that both AMPA and NMDA are somehow involved, and it may be different in different patients who recover using ketamine. In discussing the dissociative versus the trophic model, there's a lot less work on ketamine-guided therapies than there is for MDMA and psilocybin, although it's an active field. We certainly see patients who come in with the expectation of a similar model of treatment, and they report to us that they get changes in perspective, which could be attributed to an ego-dissolving experience while taking a dissociative or psychedelic compound. But it's not totally clear to what extent this does or doesn't relate to their antidepressant response. Many patients appear to benefit without any report of such expectations or experiences, and rather have this mindset that they're going to go into a calm, quiet environment, take ketamine, it's going to do something to their brain that improves circuit function, and those patients seem to get better just as much as the other category. So in terms of evidence for sort of a 10,000 foot view of the evidence base, there's the initial studies, and this was the first of them, showing rapid efficacy of ketamine. An interesting counter to that, though, is a study done in 2019, published in the American Journal of Psychiatry, which showed that a series of 6 treatments given over 2 weeks, if you looked at who recovered, half of the patients who showed benefit didn't show benefit till after the 3rd treatment. And that is sort of a game changer in terms of initially you would do 2 or 3 treatments with ketamine. If there was no response, you would stop. And that's certainly not the case anymore. One wonders if this reflects different mechanisms at work in different people, or if it reflects the idea that you just have to keep going for the same mechanism over and over again in some patients. But it certainly is a little bit different from the idea of a rapid response within hours or minutes to ketamine that we all think about. There's definitely efficacy of ketamine for patients with treatment resistance. And there's definitely an almost separable effect on suicidality. And that is, this study is the work of Mike Rimbaum and John Mann here. The interesting thing about this study is that a single infusion of ketamine produced lasting effects on suicidality, extending far out from what you usually see as the effects of on depressive symptoms from a single dose of ketamine, suggesting that there may be some different mechanisms for direct effects on suicidality as compared to depression. More recently, S-ketamine, the S isomer of ketamine, has come into the picture, given through an intranasal delivery system. And the reason for its development was, I think, one, to have an alternative to IV administration, sort of less infrastructure and so on. And secondly, because frankly, intranasal ketamine is a patentable compound, as is the delivery system, and a patentable compound merits the attention of a company in terms of going through the whole FDA process. S-ketamine did receive FDA indication, although the FDA determined there should be a REMS, a risk evaluation mitigation strategy registry for patients receiving S-ketamine due to the perceived risks in comparison to conventional antidepressants, both medical risks and risks of abuse. There was one of the early pivotal trials, and this has been a point of criticism for S-ketamine, that failed to show efficacy. But in fact, when you take all the data from the initial pivotal trials used to obtain the FDA indication, it does show efficacy over oral antidepressant plus placebo. And that's an important point to know, that when S-ketamine has been tested, it's always been tested with a concurrent antidepressant. It's not necessarily clear what the role of that antidepressant is in its efficacy, but it's a presence. And that's in part because in order to allow its use, the FDA insisted that that would be the structure of the clinical trial. Intranasal S-ketamine has a separate FDA indication for depression with suicidality. And the other important thing to note about intranasal S-ketamine is that there have been clinical trials, large clinical trials, showing long-term efficacy for maintenance up to a year. In comparison to racemic ketamine, there's a single non-inferiority trial, but in that trial, both compounds were given IV, so it's hard to extrapolate the results to intranasal S-ketamine. Intranasal S-ketamine certainly has practical advantages that come with the FDA approval. in terms of accessibility to patients. And it does not require an IV, so it requires less infrastructure, which in many areas is actually a significant consideration, perhaps less so in New York. IV racemic ketamine probably allows more control over administration, and there's likely faster absorption and elimination with higher peak concentrations of both drug and metabolites, but it's not clear what the significance of that would be. For comorbidities like OCD and PTSD, most of the evidence base is with IV racemic ketamine. That doesn't mean that intranasal ketamine wouldn't be effective, but we just don't have that information to the same degree. In general, though, at this point, there's no particularly strong evidence supporting one over the other for treatment of depression in our patients. And so practical considerations become most important in determining which one to use in those situations. Safety concerns that people think about are a psychiatric response during the infusion, though very few patients become markedly distressed or agitated. There are cardiovascular issues, potentially autonomic activation, but again, the blood pressure increases tend to be modest, and we rarely have to use any kind of auxiliary medications to treat patients during an infusion. There's a small chance of people getting cystitis, but that's mostly been seen in populations who abuse ketamine. There's a theoretical concern about cognitive effects that comes from the pain control protocols that use much higher concentrations given continuously over 3 days. In practice, in psychiatric dose ketamine, what's been seen is either no effect in long-term maintenance studies or short-term effects on where cognition improves because the depression improves. There's a concern about possible worsening of illness, but it's not something we would see very often. And if it occurs, it's more likely in spite of rather than because of treatment. And there's the concern about substance use issues, which occasionally emerge, but does not seem to have emerged as a very major problem. The evidence base starts to get very sketchy when you get to maintenance. There's small studies with IV racemic ketamine that go weeks to months and a few case reports longer. There's, as I said, a much more robust database on intranasal esketamine maintenance, but it only goes up to about a year. And the issue here would be that we know in many outpatient ketamine clinics, patients are maintained for extended periods of time that can be more than 2 years. And we have very limited evidence about what happens during that period or how you get patients out of that phase. In terms of who should get ketamine, mainly the first thing is to think about patients who have treatment resistance. And in fact, in order to be able to give patients ketamine, to get authorization for it from the insurance companies who pay for the drug, you often have to demonstrate treatment resistance. It should be remembered that ketamine, along with TMS and ECT, is an interventional treatment that has a much higher rate of success after a failed second or third antidepressant trial. So it's in that category of treatments to use in those who show treatment resistance. I would also want to mention just treatment intolerance can be as bad as treatment resistance in terms of patients not being able to find something that can treat their depression. And sometimes the interventional treatments become useful for those patients as well. Over time, as safety is established, you wonder, though, if ketamine treatment would be extended to less treatment-resistant patients who've had long periods well, and instead of taking a daily antidepressant for a long period of time, might have a brief ketamine treatment followed by a taper to a short maintenance, and then perhaps have a prolonged period well. Ketamine may also be considered in high acuity because of its potential for rapid actions. And there's active investigations, including a study that Mike Brunbaum's doing in the ER here, using an ER in hospital settings. In doing this, it's important to remember that the effects can be transient. So you really have to have an infrastructure for kind of catching and monitoring patients who respond initially, but then don't sustain their response. Certain comorbidities may lend to consideration of ketamine over other interventional treatments and other antidepressants, and those include OCD and PTSD. Contraindications would be current ketamine abuse, history of ketamine abuse, and active substance use disorder, untreated cardiovascular illness that's serious, cystitis, hepatitis, and psychiatrically active psychosis or a history of schizophrenia spectrum illnesses. Somebody might have had a psychotic illness in the past that's an affective disorder, and that wouldn't necessarily be an absolute contraindication. Current pregnancy would be a contraindication because we just don't know what the effects might be. I like to think also in terms of yellow lights, sort of things that give you caution. So the history of a substance use disorder, but with a prolonged period of sobriety, you might consider ketamine treatment, but it should be done with more caution. Similarly, with history of the kinds of medical problems we discussed that are active contraindications when those problems are active. History of hypertension or current hypertension, treated cardiovascular issues require some caution. Blood pressure sensitive lesions, just like with ECT, although there's a lot more leeway because the blood pressure increases are not nearly as high in ketamine treatment as you see with ECT. Patients having a strong dissociative tendency, that might be a sort of a caution, but it's not an absolute contraindication. History of psychosis without current psychosis, that's not a schizophrenia spectrum illness, also not an absolute contraindication, but a note of caution, and things like rapid cycling and mixed states. Things that are not a reason not to treat are old age. There's some indication that maybe the efficacy is lower, but we see many patients who are older who have good responses to ketamine. Bipolar depression, if there's adequate monitoring and adequate mood stabilization, bipolarity is not a reason not to use ketamine. Mild dissociative tendencies would not be a reason, and you can have a concurrent use of an MAO inhibitor with ketamine. In offering ketamine, we often offer other interventional treatments alongside. The patients whom are likely to choose ketamine may prioritize speed of response over other aspects. And in terms of risk and efficacy, ketamine is sort of in the middle compared to ECT and TMS. Its weak point is really durability. If patients are not willing to do a longer maintenance, other treatments may offer more durability of response. In terms of what treatment looks like. So we start with a comprehensive evaluation, and an interventional psychiatry evaluation is basically a general psychiatry evaluation, but with emphasis on the course of illness, because our treatments are episodic, and so we really want to understand how the points of intervention are going to relate to the usual points of change in a patient's condition. Also, treatment history is very important, particularly because we're considering treatment resistance and treatment intolerance against the higher risks of interventional treatments. We certainly look at their support system and treatment team. We do the usual kinds of medical evaluations. Our medical evaluation could best be described as an anesthesiologist's bedside history. It's a review of systems with an emphasis on cardiopulmonary and anesthesia risks. And then we look at specific risk for ketamine for ECT and TMS, for example, pressure-sensitive lesions, seizure history, devices or implants, that kind of thing. You do basic labs and a cardiogram on every patient, and you do the usual kind of due diligence screening for medical causes of depression that may be have been left unexamined. Very important is to do a parallel history and plans for collaboration with psychiatrists and psychotherapists. A lot of places providing ketamine completely omit this. And I've even once or twice had the experience of having patients in my general practice get ketamine treatment without my knowing it until after the fact. And we think that shouldn't be done. We think that the primary treatment team should always be on board. In terms of the treatment itself, should be given in a medical setting, which provides a sense of safety, continuous monitoring, nursing staff or others on hand to help with contingencies, and a calm, quiet setting. Beyond that, we don't know too much in terms of, should they listen to music? Should they look at art? Should they think about their problems? All of those, there are reasonable arguments to make about all these things, but there's just not clear evidence that one thing works better than another. And at this point, we're mostly trusting patients to kind of guide themselves. There are certain things we tell them, like, don't text your friends while you're doing this. Don't take business calls. We've actually had to have patients stop taking business calls while they're getting a ketamine infusion. But in general, we don't know that much in the way of specifics about the treatment setting. In terms of practical considerations, the biggest practical consideration usually amounts to cost. Because IV racemic ketamine is not FDA approved, it's not covered by insurance. The drug cost is generally included in treatments which people charge ranging from $400 to $1,000 per session. It's sometimes possible to shift some of the costs using E&M codes, but you can't specifically bill for administration. Intranasal ketamine, because it's FDA approved, all of the drug and much of the administration cost is covered by insurance. The cost of esketamine, though, is very high. And so most of the insurance companies have fairly detailed prior authorization processes that you have to go through in order to get the drug covered. The biggest practical aspect of that is if you're giving esketamine because it might work rapidly, now you've thrown another stumbling block in front of starting the treatment. And so you have potentially an additional delay. We try as much as we can to have this take place concurrent with the evaluation process, but it nonetheless often can cause unneeded delays in instituting the treatment. Other practical considerations are the patient support system. If they don't have much of a support system, including people to accompany them to treatments, you may need a longer recovery time before you can safely send them home after a treatment, and you may have more arrangements to check in on them as they're getting treatment. In terms of the treatment itself, depending whether you're doing intranasal or IV, the patient comes in, inhaler is given or an IV is placed. If it's intranasal, it's a 56 or 84 milligram inhaler given in 2 or 3 separate inhalations that are spaced 5 minutes apart. If it's IV, it's an infusion dose of 0.5 to 0.8 milligrams per kilogram given over 40 minutes and about 50 cc's of saline. All through the treatment, there's pulse ox, blood pressure and heart rate monitoring. It's more frequent, like every 10 minutes or so for IV. It's just 3 times before, during, and after for the inhale treatment. And in general, patients are monitored for a period that covers about 2 hours. You give ondansetron, olanzapine, lorazepam, and amlodipine for subsequently nausea, which is very common, agitation, which is uncommon, and increases in heart rate or blood pressure. We almost never see heart rate increases. We do see blood pressure increases, but the vast majority of the time they're within 20 to 30 points systolic and don't reach a level that you would treat. You just kind of watch it go back down. The patients recover for about 30 minutes to 2 hours. If it's intranasal, the REMS requires a 2-hour period of observation. They should not drive or operate heavy machinery or make business decisions or things like that immediately afterwards, but they can resume normal activity the next day. Most report no persistent adverse effects. Occasionally, on rare occasions, we've seen patients who, at home or out in the wild after treatment, have panic attacks that have a dissociative quality. Those have always gone away within a couple of weeks with treatment with benzodiazepines, which we've then been able to stop. And it's only happened a couple of times. Initial treatment is 2 to 3 times a week for 2 to 3 weeks for IV, followed by a variable taper and maintenance scheme. Intranasal treatment is more structured because of the REMS and the FDA requirements. It's twice a week for 4 weeks, once a week for 4 weeks, and then variable maintenance for 2 to 4 weeks for an indefinite period. And it's interesting, during that second month, we still sometimes see further improvements from what happens in the initial phase. There can be occasional boosters during maintenance. And as I said, there are very large numbers of patients in outpatient treatment who are getting long-term maintenance. And a lot of that data is really not captured into the literature right now. The largest and longest studies for maintenance are for esketamine with an oral antidepressant. The SUSTAIN 2 trial showed safety and efficacy over a 1-year period. There was no tachyphylaxis of the antidepressant effects. In practice, we sometimes see patients report becoming a little bit more symptomatic just prior to a maintenance treatment, but never as bad as before they started treatment. And there's no decrement over the long term. One thing that's interesting, though, is over time, there is a decrement in the dissociative effects experienced with each treatment. So over time, the dissociation doesn't seem to need to keep taking place in order to maintain the antidepressant effect. No cognitive issues were noted in the SUSTAIN trials, minimal instances of cystitis, no real evidence of a pattern of widespread abuse of the drug. In our clinical experience, patients who have long periods well or who have bipolar spectrum illness on mood stabilizers seem to be able to leave maintenance. So a lot of the questions have to do, for future development, have to do with what you do after people get ketamine. Can you maintain them indefinitely? Are there other agents with similar but different mechanisms like metabotropic glutamate agents that would work for them? Can we identify people who don't need maintenance? Would a longer induction period allow us to hand off more easily to conventional antidepressants? Could you take over from ketamine with TMS? Other questions would be, what's the potential role of ketamine-guided psychotherapy in treating depression? How does it relate to the other more psychedelic compounds? And lastly, can you get the effects of ketamine without the adverse effects leading to take-home therapies that wouldn't require the kind of monitoring that we now do? So I just want to acknowledge all the people who've been involved in the Columbia ketamine clinical program development and hand it over.
Thank you very much, Josh. That was a great talk. I encourage people to put questions in the Q&A, which we'll get to at the end of the final talk. I'd like to introduce now Dr. David Hellerstein. So we're going to shift gears from a currently available treatment to something that was studied decades ago and is coming back onto the horizon as a very active area of investigation, which is the use of psychedelic interventions and associated with psychedelic assisted psychotherapy. So we're really lucky to hear from Dr. Hellerstein today. David completed his undergraduate studies at Harvard, his medical training at Stanford, residency training in psychiatry at Cornell, and fellowship training in public psychiatry here at NISBE in Columbia, where he is currently professor of clinical psychiatry and director of the Depression Evaluation Service. David has conducted some pivotal clinical trials of chronic and treatment-resistant depression, including several pivotal multi-site studies. With collaborators in the department, he's done very important work looking longitudinally at antidepressant effects with neuroimaging, making important contributions to our understandings of mechanisms of oral antidepressants. And in recent years, as we will hear about shortly, he has turned his attention to the evaluation of psychedelic interventions. I'll just also mention that David is also has a very impressive writing career that works in parallel with his scientific career. He's received national recognition for his literary writing, has published works of nonfiction and fiction in magazines including Harper's and the New York Times Magazine. He's been awarded the Pushcart Prize and numerous McDowell Colony Fellowships for his literary work. So we're really thrilled to have David speak with us today. The title of his talk is, Will Psychedelics Be Good Medicines? A review of recent and ongoing studies of classical psychedelics. Thank you, David.
Oh, great. Thanks, Jeff, for the kind introduction. Can everybody see my screen?
We can.
Okay, perfect. So, yeah, so this is a really fascinating kind of ride, and I'm going to run people through it, and I may go a little fast, but certainly can address things as we go forward in questions in the discussion. Let's see. Okay, so my disclosures, grant funding and so on, scientific advisory board on a startup psychedelic company, some honoraria. And so let me give a really quick sketch of background. Everybody probably knows that psychedelic drugs have had a long history, indigenous religious use for really millennia. There was a surge of interest in the 1950s and 60s. There was a ban with the Controlled Substances Act in 1970. A resurgence in recent years. Michael Pollan's book, How to Change Your Mind. Isla Waldman wrote a book about microdosing. And I'd like to actually look at the quote on the right side, the kind of tone of this resurgence. For our species, I learned, this is Michael Pollan, plants and fungi with the power to radically alter consciousness have long and widely been used as tools for healing the mind, for facilitating rites of passage, and for serving as a medium for communicating with supernatural realms or spirit worlds. That's not our usual treatment that we encounter in psychiatry. So, particular frame of this type of intervention. There are multi-pronged efforts to reschedule, decriminalize, and mainstream these drugs as FDA approvable drugs. In particular, fast tracking psilocybin for major depressive disorder, Compass Pathways and Usona Institute have major studies. Even a little bit ahead of that is MDMA, which is not a classical psychedelic for PTSD through MAPS. And the social context is also that of rapid decriminalization of a bunch of drugs, marijuana particularly, and then with psychedelics specifically, things like psychedelic tourism. And so we see with this kind of sea change, there's risk of widespread use in the context of inadequate data. So from the clinical therapeutics point of view, my interest is really, will psychedelics be effective and safe medications? Psychedelic compounds, the classic psychedelics, psilocybin is found in many mushrooms. LSD, as everybody knows, was synthesized in laboratory settings. Ayahuasca is a fascinating drug. It's a psychedelic and drugged in one kind of plant and harmine from a second plant. Harmine is an MAO inhibitor that slows the metabolism of DMT, and some genius in an indigenous population figured out that this would make the maximum psychedelic experience. There's 5-MeO-DMT, which is found in the Sonoran desert toad, and actually their studies are going to be starting with that drug. The classic psychedelics seem to work by stimulation of the 5-HT2A receptor, and psychedelic effects are correlated with that in psilocybin with receptor occupancy, but there are other receptor effects, and we really do not yet know the full mechanism of action. There are other drugs with psychedelic properties. Josh mentioned ketamine, which is a dissociative psychedelic, and then MDMA, which is a substituted amphetamine compound, which is characterized as an empathogen. Now, the neural effects of psychedelic drugs, there's some investigation in clinical people with clinical disorders. There's a need for a lot more. There clearly are changes that are short-term and long-term with administration of these drugs. The short-term seems to be overall decrease across the board in brain activity. And long-term, there seem to be network alterations, some induction of entropy, changes in coupling between the medial prefrontal cortex and the posterior cingulate cortex. And it looks like there's kind of a reconfiguration of brain key connector hubs, enhancement of neuroplasticity, and basically perhaps decreasing the overconnection that you see in many psychiatric disorders, where there's sort of a broken record kind of condition of neural circuits that can't kind of get unstuck. That said, there's an ongoing question of how much the psychological experience of mystical type of experiences may be essential to their positive effects in psychiatric disorders. Now, as Ronit Kishon will tell you in more detail, the psychedelic treatments are combined psychopharmacological and psychotherapeutic interventions. Set and setting are essential. Set is the mindset, setting is the physical and social environment. On the right side of the slide shows a paper, a very nice paper from Timothy Leary, 1964, before he kind of went off the rails. Psychotherapist training is important. And the location of dosing, the room, the music playlist, all are important. Preparation of the subject, priming for them to expect certain kinds of experience. And that said, there's really a lack of research on optimal drug dose setting psychotherapy for different disorders. But beyond all that is the sense that single dose or small number of doses can lead to lasting change. Now, there's been a resurgence of psychedelic studies. This is from a paper that medical student, now psychiatry resident David Bender and I wrote. You can see the green bars are clinical subjects not in treatment, human subjects not in clinical treatment. The blue bars are the increased number of the clinical trials. And that's from 1991, there was nothing. 1996 to 2000, there were little increases. And now 2016 to 2021, a big increase in many, many ongoing studies. Now, if you want to know the efficacy of psychedelics, second wave published studies, which are 1996 to 2001, This is the literature. You can't read the slide, but please look up our paper. If you can't get it, I'll send you the PDF. Psychopharmacology, just a month ago, assessing the risk-benefit profile of classical psychedelics. But here's the nuts and bolts of it. So the great enthusiasm that we find is in the context of small numbers. There have been 14 studies, 326 subjects, 6 open label subjects, 95 subjects, 8 RCTs with 231 subjects. And in depression, you can see on the right, there have been only 5 studies until the COMPASS study, which I'll tell you about in a minute. 5 studies, 158 subjects, 2 open label, 43 subjects, 3 RCTs with 115. Now, these are wonderful, groundbreaking, and exciting studies, but they have huge methodological limitations. It's almost impossible to blind the treatments. There's a huge expectation and potential placebo effects. Studies have been largely conducted by enthusiasts, and I would say by proselytizers. So people who are really advocating strongly for the broader use of these drugs, which is fantastic in a way, but also leads to potential problems. They're largely foundation funded rather than government funded. There's some government funding, especially in Britain. The samples are homogeneous, they're not diverse, they have a lack of comorbidities. There's no data on differential efficacy. The reporting on AEs and SAEs is not optimal, and we don't really understand optimal psychotherapy approaches, and we certainly don't really understand mechanism. Clinical therapeutics were part of in depression evaluation of the anxiety, mood, eating, and other disorders division it's been under Blair Simpson, now under Roberto Luis Fernandez. Clinical therapeutics, are these going to be good medicines? And simple questions: do they work? How do they work? How can they best be utilized? And how can they be improved? Now, just the question, how do they work? There's different hypotheses with support. There's the mystical spiritual hypothesis in which the intensity of the subjective experience is associated with positive outcome. There is a neuroplasticity and network reorganization hypothesis, changes in network modularity. You should not neglect the placebo hypothesis, because these seem like the most powerful placebos one could potentially imagine. And I think there's a lot of work to be done to sort that out. How can they best be utilized? That's a fantastically interesting question for those of us in clinical therapeutics. Optimizing clinical efficacy, medication choice, dosing regimen, attaining remission. How do you best do that? How do you do relapse prevention? Should there be repeat dosing? And something that's been really ignored in studies to date, risk management. So these clinical populations are likely different from recreational and spiritual users, especially people with treatment-resistant depression, OCD, history of suicidality, potentially psychotic and other comorbidities that might not have been detected. How can they be improved? There's a fantastic line of research. Brian Roth and Olson have been doing studies with non-psychedelic drugs that are 5-HT2A agonists. Similar to what Josh was saying with ketamine, can there be work on effective drugs that don't actually cause a trip? And if they would be effective, is that even a good thing? Now, this is the study, some report of the TRD study we did with Compass Pathways. It's the largest study to date. It actually doubled the number of subjects of all modern studies in psilocybin. There's also an ongoing USONA MDD study. It's not TRD, it's just major depression. It's smaller, 7 sites and 80 patients. This was adults with chronic single episode or recurrent major depressive illness, not in response to 2 to 4 adequate trials of antidepressants. Adults age 18 to 65, Hamilton had to be moderate to severe depression. They couldn't be psychotic or suicidal. They couldn't have a family history of bipolar disorder. Importantly, they had to be off of antidepressants at least 2 weeks prior to dosing. They were given a single administration of psilocybin, either a 1 milligram, presumably inactive dose, 10 or 25 milligram, 8-hour administration session in a controlled environment. There were pre and post dosing psychotherapy preparation and sort of processing of the experience visits. The primary outcome was the MADRS score by blinded rater 3 weeks post-dosing. So here's a snapshot of our dosing setting. This is a room at PI. It's trying to look like a non-clinical room setting. It's got a comfortable bed, a couple of chairs for the therapist, pictures on the wall, sound system, video camera. We had a big startup process. I had to get a Schedule 1 DEA licensure, FDA, Bureau of Narcotics Enforcement inspections, train our therapists, set up the room. It was a big process to get started, big learning curve. And then we had a huge onslaught of potential participants, probably over 2,000 people. And we got going, we treated 13 people, and then COVID hit. We had huge issues trying to figure out how to do safe dosing in the age of COVID with testing, masking, checking airflow, then vaccination helped a lot. At the end of the day, we treated 27 subjects. We were actually the top recruiting site of 26 worldwide sites in the study. And it was fascinating. I'm glad to talk to people offline about this more, but one of the biggest challenges was managing subjects' expectations. You saw the quote from Michael Pollan. Media has amplified this. And people's actual experience for people with TRD was very, very, very interesting. It ranged from the best experience of people's life, for some people, the worst experience of their life. Post-dosing, a lot of people described changes and increased empathy, feeling of emotional connectivity in a way different than they described before, people feeling decentered from some of their prior suffering, sense of calmness. And we don't know which dose which subject got. So this is in the context of 3 doses, but it was definitely a powerful, powerful experience. It was also very clinically challenging post-dosing, pre and post-dosing, people coming off their meds. People's medicines were presumably ineffective, but it turns out that many of them have been partially effective. So people, after their private psychiatrists took them off of their medicines, would have struggled to get to the dosing session. And post-dosing, there's a lot of emotional lability. So here's the findings. They haven't been published yet. They've been presented. They're on the Compass Pathways website. You can look at them in more detail. So this is really interesting. Primary endpoint, week 3, blinded rater on the rating on the MADRS. And what you can see, I don't know if you can see my mouse, but at day 2, there's a statistically significant improvement in the MADRS, a drop of 16 points for the 25 milligram dose. There's a drop of 12 points, not statistically significant for the 10 milligram dose, and a drop of about 8 or 9 points for the 1 milligram treated patient. An 8-hour session with 2 therapists in the room is intense for everybody. Statistically, you can see that at week 3, there's a statistical difference for the 25 milligram, the blue line, versus the green line, the 10, and the 1 milligram comparison dose. And this is actually one important thing. This is a very interesting dose finding result. 25 milligrams is an effective dose, single dosing for treatment of depression. 10 milligrams is not. So fascinating finding for a dose finding study. Also, you can see that the benefit seems to wane. By week 12, it's no longer statistically significant in the sample. So that's a matter for future interesting studies. So this is another slide from that study, key secondary endpoint, MADRS remitters. And you'll see MADRS remitters almost 40% at day 2. And by week 3, it's 29%, remains at 27% by week 12. So it looks like there's a group of sustained remitters with a 25 milligram dose of psilocybin. So that's fascinating. How do they differ from the people who don't remit, and what sets that into remission for those people? Also, the non-remitters, how can you get them to remit? Treatment emergent Serious adverse events, just quickly, there was some suicidality in the 25 milligram group, not in the 10 or 1 milligram. So these are patients who need to be followed closely and monitored. There were no actual suicides, but there was a lot of emotional lability in these patients. The context of this, we're really eager to do a bunch more studies. Here we've discussed many other studies among other investigators in our department. We're completing a psilocybin for body dysmorphic disorder. Frank Schneier and I are the leads on that, and that's a fascinating population. We want to do other studies, microdose, OCD, eating disorders, Lyme, and other studies. The interesting thing, NIMH has gotten out of clinical therapeutics, out of doing clinical trials, but clinical therapeutics research, in particular clinical trials, are central to the psychedelic enterprise, to medicinal chemistry, laboratory studies, education and training, policy, obviously for neuroimaging, looking at mechanism, public health, and also for clinical services as these drugs presumably will move into clinical practice. So in the past year or so, we've discussed with myself, Elias Dakwar, Frank Schneier, and others, development of a clinical trials program in psychedelics. And the goals would be to have a state-of-the-art clinical therapeutics research program to leverage our expertise to facilitate development of compounds for new indications, to explore mechanism of action, to conduct original studies of efficacy and effectiveness, and most importantly, probably pilot data for NIH grant applications. NIH has become more open to psychedelic studies. There have been a couple funded through NIDA. NIMH did a small funding for a R21 and OCD for investigator at Yale. So the ice is kind of cracking. There seems to be interest in clinical therapeutics research from NIMH and NIDA and NIAAA. So this clinical trials program, if it does get launched, would have 4 components. There would be an incubator for innovative exploratory studies. We'd want to conduct a groundbreaking large comparative efficacy study. We want to conduct pivotal multi-site studies and develop a core facility. So the incubator idea, I think, is really a cool one. We could have many small studies if we could find funding that could be done. Some kind of internal mechanism to evaluate project ideas, provide funding. We could have cross-study biometrics, and could do all kinds of small pilot studies. I have slides in my after the end of this presentation. I could show people some of the thoughts we've had. A comparative study, this was Elias Dakwar's idea. I'm not sure if he's on today, but he wants to do a large definitive efficacy study with mood, anxiety, and substance use disorders, comparing psilocybin, MDMA, 5-MeO DMT, that's the toad venom derivative, and an active comparator amphetamine, to examine cross-diagnostic therapeutic mechanisms, neuroimaging, and long-term maintenance, switching, and so on. That would be a really cool study if someone has an extra $15 million around to provide for this study. We've made the most progress on the third component, which is industry-sponsored studies. The role with the COMPASS study, there's 4 phase 3 studies, of which we hope to participate in 3. We're also discussing potentially working as a site for a 5-MeO DMT study. We're negotiating a master services agreement from Compass Pathway that would also hopefully fund 3 investigator-initiated studies. And so we think there's a lot of room to be part of some of these pivotal studies that can provide data at a scale much larger than the small foundation-funded studies, and much more rigorously look at efficacy and safety. And then finally, the idea of a core enterprise for psychedelic clinical research and training. So it needs space, it needs staffing, trained therapists, psychiatry, DEA Schedule I certification, training and supervision. If the psychedelic enterprise does indeed go forward, there's going to be a huge need for psychedelic psychotherapists. We would love to be involved with training residents, psychology interns, and other trainees. Facilities are needed for all kinds of secure facility storage and so on. And also a core research facility could serve as to facilitate the transition to clinical psychedelic treatment and training programs. So really, in summary, it is a historic moment, I think. There's potentially huge promise. There are definitely risks. There's definitely a possibility that practice may outstrip the data. Safety risks for vulnerable populations are not trivial. There's an initiative in Oregon to open clinical centers, and that's going to happen probably in the next year. I hope they collect data on efficacy and safety in that setting. There's definitely an opportunity for significant research on hallucinogenic medications as therapeutic agents, efficacy, mechanisms of improvement, and clinical trials can be part of a broad research enterprise. And we believe that our department has unique strengths since we have clinicians, clinical researchers, lab researchers, neuroimaging, ethics experts, public policy, et cetera, et cetera. So we have a lot of strengths that could facilitate this research project. And also, not too many years away, there could be a psychedelic clinical services. MDMA is likely to be approved in the next year or so. And I would just stress the importance of collecting effectiveness data post FDA approval, because the samples that are studied in these clinical trials are very, very restricted and are not representative of patients in general practice. So that's it. So I'd like to thank our team, and then we can have discussion. So thank you very much, and look forward to talking about this in the next half hour.
Thank you, David. That was great. I am going to move us forward to our final speaker. I'm really thrilled that Dr. Ronit Kishon is joining us today. Dr. Kishon is an associate professor of clinical medical psychology and psychiatry in our department. She received her PhD at Teachers College at Columbia, her internship at the West Haven VA at the Yale School of Medicine. And she's really done a lot of important psychotherapy research here while she's been with us at Columbia and PI. She's overseen the clinical arm of multiple NIMH-funded projects, providing individualized interventions to people with PTSD, anxiety, and depression. She runs a CBT lab in the Depression Evaluation Service, where she investigates psychological and neurobiological mechanisms that may shape disease processes and affect change during psychotherapy. And related to that, she's a multi-PI with Dr. Jürgen Kaiser on an NIMH grant entitled Combining Electrophysiological, Behavioral, and Psychological Measures to Target Mechanisms of Emotion Processing and Regulation during CBT in Depression. She also directs an externship program for students in clinical psychology, and also provides training on trauma-related issues. And then in recent years, as we're about to hear about, she has been providing psychedelic-assisted psychotherapy for both treatment-resistant depression and body dysmorphia. So I'm going to hand things over to Ronit. Thank you so much for speaking today, Ronit.
Thank you, Jeff, and I'm very excited to be here. So my topic would be psychedelic-assisted psychotherapy, which I will call PAP, although I don't like that name too much, but it will assist me to be more efficient in my presentation. And as far as disclosures, as you heard, I'm funded by NIMH, and also I receive a certain percentage of salary for being a leading therapist in the psychedelic assisted treatments here at PI. When I entered this training, Compass was still a nonprofit organization. I'm not involved in the research arm, and it will be very apparent what I'm presenting here, which has to do with their training, and I don't own any of their stocks. So without further ado, I have 4 objectives for today. I want to describe to you shortly the history of psychedelic assisted psychotherapy with the emphasis of how it is being presented in our scientific community. I'm saying it because indigenous, I knew I wouldn't be able to say it. Indigenous people have been using versions of these treatments for hundreds and thousands of years in very successful ways, but I won't be able to describe that. So I will describe whatever pertains to our scientific usages. I'll present the rationale for it, for PAP. I will describe shortly how we do it here at PI in our clinical trials at the moment, and a slide which hopefully will describe the future and how we can further develop it. So I would like to start. I know David Hellerstein already gave a wonderful introduction to this whole field, but I will want to focus actually on Humphrey Osmond, who was a psychiatrist on the 50s, a British person who went to Canada and then ended up working here. And I know we all think of Timothy Leary, who maybe was a brilliant researcher, but I actually think he had some issues with IRBs, and I'm not even sure it has to do with psychedelic drugs. So as far as Humphrey Osmond's work, he actually was very interested in the intense, one could even say negative effects of the psychedelic drugs. He mostly concentrated on mescaline and LSD because he thought that could have a healing quality. Since he was interested in schizophrenia, he would give mescaline to normal people and see what he can learn about the way they distort perception under the influence of mescaline. And he also gave LSD to alcoholics with the intention to artificially create delirium tremens, which I'm sure most of you know what that is. And then usually when alcoholic person with that addiction stops drinking, they go through a period of after 3 days or so, after a period of confusion and some physical symptoms. And he was thinking, if I'll artificially induce it, most likely people, let's see if their addiction can stop. To his great surprise, he found out that actually much more positive experiences, most of them were mystical, were very helpful in the study with LSD and alcohol as far as interrupting addiction or stopping it. And one of his study participants was Bill Wilson, who later on became the co-founder of AA, which is based on spiritual states of consciousness without using drugs. And kudos to Dr. Osmond, who actually invented the term psychedelic, psyche is mine, and delos is manifest. So moving along, realizing that high dosages and what's called positive experience may be helpful for the healing. Many researchers, and I just want to stop for a minute. When I say positive experience, I don't necessarily mean that one doesn't go through some sadness or some anxiety-provoking scenes, but the idea is that it will never be overwhelming, that it will feel safe and it will be positive as a general experience. So as we were moving along, many researchers started looking at, at indigenous people around the world who've been using it for thousands of years. And everyone said in different ways and manners that there are 2 things that are very important: the environmental context, which is usually was ceremony, rituals, songs, and so on and so forth, and psychological factors. Shamans around the world and other providers of the type of plants kept emphasizing that the way a person comes to it, the clear intention, openness, inquiring attitude is very important. And Dr. Kars Harris wrote a lovely article at 2018, looking back and saying, what can we integrate for our usage? And I just want to say on this issue, one more thing about Humphrey Osmond, because I think it reflects what happens to some researchers these days, that he became interested in the Native American church and became very involved as a result of his research, but was very good about keeping the boundaries between his own personal changes and between and keeping, of course, the science the way it needs to be. And we hear these days Dr. Griffith, Dr. Rachel Yehuda, all people that are in this and are obviously doing great science, but at the same time are very open about some personal changes that they're going through. So in the 50s and 60s, there were basically three groups, three camps. Again, that's an oversimplification of a much more complex time. But on the left, you see the psychedelic therapy treatment model, which Dr. Osmond would be part of it. Dr. Bill Richard, who is a psychologist in Johns Hopkins, involved in many important studies. I'll go back to him later in that group. And basically they were saying we need to give high doses and we do need to give it in a supportive, safe manner. We are not just going to give these medications and that's it. Around that time, the psychoanalytic therapy model, I mean, let's remember in the 50s and 60s, psychoanalysis was still the main avenue of doing psychotherapy in the Western world. They were very thrilled with those compounds and they used it basically either small doses or medium level doses, and it would enhance, some of them thought it would enhance the psychoanalysis process. Peter Gesser, a Swiss psychiatrist, done wonderful work on this. The research was qualitative, if they still do it, and he still is in Switzerland doing wonderful work on this. On the right side, you see, oops, sorry about that. I was trying, the main group of researchers that thought that the controlled way to test it is not to offer any support, and one could see the reasons for that. And so they did more than a few experiments where they would just give psychedelic drugs. They were not significant, most of the results, and actually there were some negative effects. Many of those studies were done in the military, and for people who are interested, I'll be happy after this talk to offer some references. It's very interesting what they did. Then we had the whole, going underground period. And in the 90s, when this came back, we already had in the community of psychedelic therapists, there was in those underground years when some of those people continued to do research and provide psychotherapy, they did their best to plan the comeback. And so in this planning, there was this creation of what we call the rationale for psychedelic assisted therapy. And basically it is that the safety and therapeutic action of psychedelics are reliant on the context. It's, as David Hellerstein mentioned earlier, it's the set, which is the person's expectation, intentions, psychological factors, it could be the symptoms, traumas, and then there is a setting, which is the environment within our scientific community. It means the room that you already saw, and for some reason I also was taking photos of that. I guess we are very proud of this room. But this is very important because it basically says that in order to provide this medication or those medications, you need some level of therapeutic support. And to emphasize that, there is a very important document that was written by Dr. Johnson, again, Dr. Bill Richards, and Dr. Roland Griffith in Johns Hopkins. And these are guidelines for safety and minimizing risk when offering psychedelic medications. So first of all, of course, is patient selection, which we always do in our clinical trials. I have an interesting anecdote to that, since I've been for almost 30 years treating also in my private practice people who usually have severe mental illness. Once in a while, to my great horror, I hear that they're stopping all their meds and they're going to somewhere to to South America or God knows where, and they're going to have some kind of a journey with a shaman. And if they go to a good, reliable shaman who probably his ancestors kind of had laid it down from generation to generation, this way of healing, they usually come back and they tell me that I cursed it, because I'm usually very much against it. Many times the shamans decide not to offer them the plant, and they themselves take the plant and just they're part of the ceremony. So it's not only us that are thinking that, yes, we do need to select the right people for this medication. Preparation. If you're receiving this medication, you must have few sessions of preparation. And besides the logistics, of course, and a lot of explanations, you have a therapist usually, and later on another therapist joins in the process. And if we need to establish a trust, a rapport and trust between the therapist and the patient, that creates a whole new world to therapists like myself, not because we're not busy creating trust with our dear patients, but because we have to do it in a very short time in order that the administration of the compound will be safe. What does it mean? Yes, sometimes you need to be very friendly and warm and know to laugh from jokes, but sometimes you have to be very reserved and professional. You basically, as a therapist, need to see what works best for this person who you're going to spend with 8 hours in the room, and in what ways they can trust you the best. I can obviously give a presentation just on this aspect. We always, there must be, and that goes without saying, that there needs to be a team at the background. It's usually our dear Dr. Hellerstein, and ready to come in if there are any level of symptoms or any intense emotions that can be too intense, because again, we do not want to overwhelm anyone. I don't remember that we had any of those occasions. From the TRD study, we had 17 patients. I was, I believe, the leading therapist of 16, and maybe another 3. I was the co-leader with 5 patients with Dr. Schneier as a leading therapist. I didn't have this occasion, I think, and that's something I should have asked David before my talk if we had any of those experiences. They rarely happen. And the integration, apparently, for excuse me, for this type of medication, thank you. For this type of medication, the person afterwards needs to reflect about the experiences. This is very important. We do know, again, from the 50s and 60s, if people just go out the door and for some reason don't attend what they experience, there is much less benefits of the drug. Now, have these things been studied thoroughly? I'm not sure I can say that in a safe way, because, you know, the samples are usually small. The 50s and 60s only went that far. We had all the fallout. We are now starting again, but definitely in the way that it needs to be administered, this is what we call part of the guidelines. And so that brings us now to Compass, who took upon themselves, and I'm not sure if they're the only ones or not. I'm not so involved in the more economical, political aspect of it, but they would like that their psilocybin will be approved by FDA. And the psychotherapy assisted, the psychedelic assisted therapy that we are offering comes with it. So it will also be approved by the FDA. And the best way to describe it would be that it includes non-specific active psychological support that intends only to facilitate the effects of the drug with no additional modality. Now, obviously, at this era, we are much more prepared to do that, because now that we have evidence-based treatments, we had them much less, if at all, on the 50s and 60s. In many clinical trials, we have what we define as support therapy. I mean, even in our grant, my grant with Dr. Jürgen Kaiser, we have the control group with support therapy only. So we don't see it as an intervening, that it has intervening aspects. Of course, we could debate about that forever. And the main reason I've joined them is because both Bill Richards and Peter Gesser, now you'll have to think back of the slide 2 slides ago, they were busy in creating this training. And so there was no way I was going to miss this opportunity. Just on a very kind of professional, personal note, as I came back after my studies in the United States, I had a very magnificent internship at the West Haven VA. It was just the time that Vietnam veterans were provided with psychotherapy for PTSD, and Charney and John Crystal and myself would have all these ceremonies of grieving the soldiers with the other veterans. So I came with a very kind of an active stricken me to be a trauma therapist, and I am since then. So when I came to Israel and started treating people there, they would tell me that in the 50s and 60s, they would be given this pill, which actually created a flashback, and the doctors and the nurses and the therapists became part of the scene, the enemy, this and that. So I, was very intrigued by this. So I kept kind of keeping my ears open. And as all trauma therapists know, there is so little we can do sometimes for our PTSD patients. So we're always looking for new methods. So my main reason to join was because the involvement of Bill and Peter Gasser. I want to introduce to you our team. Beside myself, we have 3 wonderful therapists. Each one of them comes from a very different perspectives, but we are all doing our best to provide the psychedelic assisted therapy in the clinical trials. On the left is Dr. Wang. She's been a resident here. I'm sure many of you know her. Dr. Kelly Skies is another wonderful clinical psychologist who does a lot of work with families and adolescents, and Dr. Alexander Carmago. Again, 3 different approaches, but we're all in this, and it's a wonderful team. Now I'll go to the preparation as it is done. I'll just emphasize for the sake of time, just few things. As I said already about the Therapeutic Alliance, a strong issue, a big issue is the issue of touch. I touch the patient when I try to arrange their blankets. I touch the patient as they're going to the bathroom and need someone to hold them. They need to keep the toilet open in case they get meaning the door is locked, obviously, is the door is closed and not locked in case they get too psychedelic in front of the mirror. So there is even a chance that one of us will need to go in. So obviously the boundaries are different. We discuss all of that in a very transparent way in the sessions before, and we see how different people think of that and what's their level of of how they would like it to be. But again, it's all to maintain the sense of safety. We review the symptoms that they came for, the reasons that they decided to join the study, and from all the different levels of psychoeducation that we do, I chose to emphasize 3 issues. First of all, is being an active participant. Many of the people that are coming to us are very vulnerable, have had symptoms too many years, and they're really looking finally for the magic pill that they can just swallow and feel much better. And in many ways, they may deserve it, but this is not the case. During the dosing, they need to be very active, diving into the experiences. We're calling it going in and through. Because no matter, even on the high dosages or doses, even on the high doses, we notice that you can still be on the avoidance side, and then you gain much less. So we really reinforce in any way we can, and telling them that we'll be near them as they need, to dive into the experience and let themselves experience whatever comes up. Letting go of any expectations, which basically means if you read the Michael Pollan book, please erase it. Don't think of it. You really need to come open-minded. We have no idea what will be your experiences with the psilocybin. We can only say that they can be very meaningful, but we do our best to have them forget anything they read about it in different books or social media. And the logistics of the study, which is, what are you going to eat in the breakfast before you come in, and don't bring grape juice, and who will come to pick you up, and all the logistics of the day. Person might feel a little bit nauseous. We make sure to feed them when that's the case, and so on and so forth. I don't have enough time to review all that. We do want not just to review their intentions, but any concerns they have about negative events. Some do get paranoid at one point. And since it's a very inner experience, and that usually the person doesn't talk much, I'm talking about the high dosages. In the TRD, we had people who received very little dosage, which one could say had almost no effect, and then the mid-level. So there are differences there, which I won't go into. But if we think of the high doses, the high dose, then usually it's a very inward experience. And we, as the clinician, as a therapist, we can see them, crying, we can see them going through emotions, but we don't necessarily know what they're going through. They can get sometimes paranoid. I usually see it when they're looking at me and they're like, and it's always a question if to interrupt their process or not. Usually we didn't need to. If we think that someone is a little bit went too far with some level of paranoia, we ask them to, we kind of ask them how they are and so on and so forth. And the two more things, I know, Jeff, we need to end soon, but two more things I would like to emphasize is practicing self-directed inquiry and practicing experiential processing. So let me be a therapist. We really love to play role whenever we can. So basically, I'll be now the patient. We really train them to be in the experience. So it would be, Ronit, what are you feeling at the moment? Well, at this moment, I'm feeling some level of stress, some level of excitement. How is it for you? What does it feel? Where is it in your body? And so on and so forth. So nothing that, has kind of what we consider from a more evidence-based treatment. And we have the grounding techniques. Again, this is the room. The master of ceremony is Manny, that some of us knows, and he's part of the journey, bringing food, doing all kinds of things. Kudo to you, Manny. And during the administration day, there are 3 clinical observations that I would like to make very fast, and they're just clinical observations. There is no reliable data to support it. First, I've noticed that very few of them have described afterwards having mystical events unless they have a background to allow it. They can be describing things that someone else would think they're mystical, but people would call it, oh, I really enjoyed it, I really loved it, I felt so great, but they won't necessarily put, so it means that whatever in my therapist's mind, it means whatever the person comes with is important. One anecdote that a very religious Jewish person said, and I can say it because I'm Jewish myself, he said, well, I'm not sure that the Jewish God comes to psychedelic trips, and whatever they were describing seemed actually that some other people would consider as mystical. I also noticed there is a lot of psychological scenes with family members, interpersonal relationships that keep coming to the mind. I hear about it later. I don't hear about it during that time. Another observation is that they all seem to have a lot of somatic experiences while the dosing, the pain and aches, it's not so easy. Later on, I hear from more than few people that some of their chronic pain went away. And the last thing which I observed in many, and they say it, that there is a certain level of agitation and stress that went away. And they say it by the end of the dosing, and they say it also a few weeks. Again, just clinical observations. Integration. They come back and we, in a very minimal way, ask them questions about because we don't have that much time. We have maybe 2 sessions at most afterwards, what they went through, the reflection, any insight. That's where therapists like me really are hoping that this phase will involve so much more, because they can look very animated and look better to us, expressing many more emotions. And seeming much more lively in the room, and they think that there is nothing that has changed. And I'm almost done with a quote by Ram Dass, who I think some of us heard of, and he actually used to be Richard Alpert, who did some work with Timothy Leary, and also had to leave Harvard at one point, became a spiritual leader. And he said something very interesting, which to me ties very much to the integration. Psychedelics could chemically override the thought patterns in your brain so that you're open to the moment. But once the chemical loses its power, the old habit patterns takes over again. For love slowly transforms you into what the psychedelics only let you glimpse. And in that note, I'll go to my last slide, which basically is all the potential that still we have as far as, I don't think just with the psychotherapy, it could very much, and I know sometimes David and I have those discussions, whether the psychedelic drugs facilitate other treatments, maybe they can facilitate the medications that come after. But again, we're dealing with people who have suffered, have mental illnesses. We can't think that we'll be giving it to them and everything will be fine. At the same time, it does seem that those medications can open the door and maybe facilitate many of our evidence-based treatments, which Dr. Myrna Weisman and myself thought so 2 years pre-COVID, and I think we wrote a very good proposal for that. Myrna, I'm still looking for the money. I'm not giving up, but at this point, a lot of the funding goes to just see whether those compounds work in reducing the symptoms.
Ronit, I'm going to pause there. I'm so sorry, but we're almost out of time even for our
Okay.
discussion section, just because there was so much to cover with these 3 very interesting talks. Do you mind if you could stop sharing your slides? And I'm going to
Sure.
propose, if people can stay, because we're almost at the end, maybe we'll extend till 12:35 or 12:40. We totally understand if people have to get off. I'm going to give the first question to a trainee, Jared Airy. Jared, if you want to unmute and ask our first question.
Of course. First of all, thank you so much for sharing. I think it's really exciting, everything we're doing with innovative therapeutics, and really impressive what we're doing here at Columbia, really to further the field. My question is, like, for patients who have treatment-resistant depression, have gone through a lot of really good oral psychotropic trials, meaning good evidence-based conventional psychotherapy. I have a few patients on my panel like this, and I'm trying to figure out kind of like where to start. Like, would I start with thinking about doing ECT or TMS or ketamine, or maybe in a few years when it's maybe FDA approved or allowed, doing psychedelics as a first line? And I'm just curious if you guys have thoughts about kind of what you think about, or what often kind of leads you in one direction or another in terms of how to kind of take the next step with treatment-resistant patients.
Does anyone want to start with that?
I'll jump in. So, you know, the first thing is that all of these treatments work more often than our conventional treatments for the most part, and in patients who have already shown treatment resistance. And almost all the patients, by the way, come and they say, I've tried everything. And usually they haven't. So that's actually the first important thing. Say, no, you haven't tried everything. We've got lots more things to do. You know, just as it's important in the psychedelics, managing expectations is actually important all the time. And so, you know, the first thing is say, okay, you haven't responded to all these things. We're going to figure out not just one treatment, but we're going to figure out a treatment algorithm of what we want to try. And we're going to figure out what you want to try first based on what's important to you. Some of these treatments tend to work faster. Some of these treatments have higher or lower efficacy rates, but we can't really predict at this point with markers. We just don't have that kind of information. You know, what's going to be specific to you. So let's figure out what are your priorities and which of the treatments best meet those priorities, and let's do them in that order. And I think that's a reasonable approach to this. Obviously, some patients present particular reasons why they couldn't have one treatment or another, and so you take that into account as well. But in general, right now, you know, getting the patient to sort of let you know what's important to them, and then you'll figure out what to do.
Great.
I also would like to answer this very fast. As a psychologist and seeing all the mind manifesting things that come up, in my mind also with ketamine, I'm usually quite careful. I want to know that they do have the support they need afterwards. It really does, on many levels, opens the door to unconsciousness. So do they have a therapist afterwards they can work with? You know, if they tend to dissociate, if I see in my practice that they have very hard time going back to traumas and processing them, I would be cautious at this point before we do more studies. But that's a very psychological response, obviously.
Great. And our next question will be asked directly by Megan Finsis, if you'd like to unmute.
Thanks so much. Really interesting talks. Thanks for sharing all your work today. My question is for David in particular. I just was really curious about the increased mood lability that you noted. Something that I haven't really heard much about, certainly not like in popular media and not so much in the literature, although it's not my area. And I'm just kind of wondering in particular, like from the perspective of the patient phenomenologically, could you speak to like what that's like for them? Is it experienced as thrilling or alarming? And then do you see it as being opportunity or danger? I'm just really curious about that mood lability piece, if you could share a little more about that.
Yeah, thanks, Megan. So I think it is under described in the literature. And I think the sort of basically hype from many studies has probably downplayed that or diverted attention away from that. I think in this study, since people were taken off their putatively ineffective medicines, they are in a state of being unmedicated, probably in some degree of withdrawal from the SSRIs or other medicines. So I think that probably plays some role. And by the way, there are studies of continuing antidepressants during the time of psychedelic treatment, which are being conducted and will be conducted. So that will actually be an interesting thing to look at when that data comes out. So, but I think it's a range of probably physiological and psychological experiences, some probably related to the medicine, some also related to, in a double-blind study, gee, I didn't get the effect as intensely as I wanted, maybe I got the placebo. So there's both placebo effects and probably nocebo effects. So how does that play in to the experience? We're doing an open label study with body dysmorphic disorder. Everybody knows they're getting 25 milligrams of active drug. And I would say we've seen that much less, the disappointment component. So I think that's another piece. But I think inherent to the psychedelic drug, there is more experiencing of different kinds of emotions and intense feelings, and as I think Ronit is talking about, preparing people to be able to accept and experience and kind of go through the experiences. One person that was in a study I use as an example, where she went to a class, and after her dosing, like a yoga or mindfulness class, she's heard someone else talking, and she was like, oh, I realized this person's actually having problems in their life. And I really felt for him, I felt for her. And it was like this sense of empathy and warmth and connectedness, which she then experienced in a number of other interpersonal settings in the following weeks. So that seemed to me to be a loosening up of defenses, boundaries, that was in obviously a more positive way.
Thank you, David. Josh, there's a related question for you from a trainee, just as David was talking about discontinuing versus not discontinuing medication. You were asked if there are data on the difference among trainees or among patients with treatment-resistant depression who remained on their prescribed antidepressant medication while started on ketamine versus those who completely discontinued previous antidepressants.
Yeah, so I don't think we have that much data about that. That's an interesting sort of area of potential investigation, both for what happens during the treatment and also, for what could happen during a maintenance period, and whether you can get patients, to a ketamine-free maintenance period. But I think the answer is there's just not too much known. Some patients stop everything for intravenous ketamine. The other thing is for S-ketamine, there's actually a requirement that they be on a concurrent antidepressant, and that's usually observed. So there's not going to be that much data from the clinical population to answer that question. I just briefly wanted to touch back on the other question. We see lability with the ketamine patients sometimes too. I don't necessarily hear people talking about after treatment these kinds of increases in interpersonal connectedness, other than what you might see from recovery from depression, which is less than what David was describing. But we do see, lability certainly in the treatment setting. And the other place where we see this actually sometimes is an emergence from anesthesia after ECT. So for some of our patients, but not all of them, the experience of some kind of alteration in consciousness may, kind of unleash a kind of lability that they're not showing in other circumstances.
Thank you.
If I have to interject one thing, the psychological perspective, and that is that usually when people start feeling more in psychotherapy land, that's not a bad thing. And we think that's part of the treatment and healing. But of course, you need to have the people to process it with. And another thing I wanted to inject, and again, it hasn't been studied, but in the psychedelic field, we think that the different compounds may do different things. So for ketamine, we usually think, and again, it hasn't been studied, these are just the things we talk about, that it's more you become kind of an observant of whatever your experience are, and you're kind of on the outside, and mostly without anxiety, you can look in and see what's happening. Psilocybin, we think more, and that's again based on people who did that and are still doing it. It's kind of a more inner, let's dive into it. And MDMA is really, it's ecstasy. So if you process things while you're with ecstasy, then obviously there are more, positive feelings like warmth and feeling connected and all that. So there's also some issues of boundaries, because some people during that can have some sexual feelings, and as therapists, you need to be able to address that. But just to say that, yes, people do feel more many times, and it really depends what you do with it. It doesn't necessarily needs to be a negative thing.
Thank you, Ronit. That's really valuable context. I'm going to try to get through 2 more questions, and then we'll finish by 12:40. Josh, Meg Haney asked you if you could explain why substance use disorders are exclusionary, and is it for all substance use disorders? And that made me think about Elias Dakwar's work as well, in which he's used ketamine as a therapeutic intervention for people with different substance use disorders. So I'd love your thoughts about that.
So first of all, history is not an exclusion, it's a caution, but it's not an exclusion. I think we don't want active use during a treatment because of the potential disruptive effects on the treatment. And we'd be concerned about specific, ketamine abuse, which is actually pretty uncommon, but not non-existent, just because it's even just the possibility that the treatment itself starts to fit into a pattern of abuse of the drug. But we certainly have people who have had substance abuse histories. Where it gets to be tricky is, how far from an episode do you insist on separating? Because we know, of course, we don't want to deny treatment for a mood disorder to people who have substance use, where the substance abuse and the mood disorder may be intertwined. But it's not an all or nothing thing.
Thank you. And then our last question for today will be from Michael Avisar for David. He says, for neuroimaging or EEG studies, the set and setting will be different than purely therapeutic behavioral studies. Would the core also be involved in setting up procedures for how to manage patients who are dosing while getting scanned or while doing EEG?
I hope we're lucky enough to have such a core and that we get sufficient funding to set it up. I think that the context of being a psychedelic participant in research is quite different than getting psychedelics in a spa setting or a very comfortable clinical setting. And I think that ideally we would have the expertise to do that, so that taking psilocybin while you're in a scanner would be a pretty challenging event. It's been done. And similarly, EEGs and other kinds of testing and evaluations. And I think if we're able to get this launched, then I think that would be a really important thing to do, to have the capacity to support dosing in kind of demanding research settings.
Well, thank you all. I want to thank all 3 of our speakers for an amazing session today. There were many more questions than unfortunately we had time to get to, but I think that just speaks to the interest of this area, and hopefully this will be the first of more conversations in our department about this. Thanks again.
Thanks for having us, Jeff.
Thank you.
Yeah.